I'm super excited to kick us off with our incredible keynote speaker. So today we have joining us is Dr. Dhairyawan, who's a doctor, researcher, and an author. She's an NHS consultant in sexual health and HIV medicine at Barts Health NHS Trust and deputy director of the Share Collaborative for Health Equity, Queen Mary University, London. She has held numerous advisory and charity positions for organizations including the British HIV Association, British Association of Sexual Health and HIV, for a Mentor Mothers Network, CIC, and NAZ Project London. Rageshri was named as a woman changing the world on International Women's Day in 2019 by iNews for her work advocating for the needs of racially minoritized women in sexual health. She's an experienced science communicator and authored Unheard, The Medical Practice of Silencing, an incredible book. This is not part of the speech, but just absolutely incredible. Definitely read it if you have not read it yet. And it's contributed to the anthology No One Talks About This Stuff. She's an inaugural Welcome Collection X Spread the Word Nonfiction awardees. So let's all do a quick Zoom, high five, clap, whatever it might be to welcome our incredible keynote speaker. Thank you so much for joining us here today.
Hello, everyone. Thank you so much for that lovely introduction, and thank you so much for the invite to speak today. It's such an honor to be invited to speak at the conference today. So I'm going to be talking for about 25 minutes, and then hopefully we'll have 10 minutes to have a bit of discussion, Q&A. So I'm just going to attempt to share my slides, which did work earlier, and then we'll get going. Lovely. So hopefully you can all now see my slides. Great, thank you. Um, so yes, today I'm going to be talking a bit about my book, which Daria mentioned, which is called Unheard: The Medical Practice of Silencing, but also a bit about kind of my journey to getting there. And I think hopefully you'll see the theme from this talk is really around the issues of medical silencing, with some kind of personal experiences of my own, but also thinking about how I found my voice, how you can find your voice, and also how we can really listen better and amplify the voices of those who aren't heard. So I'm going to take us back in time. Second. Yes, here we go. So this is 1983, and this is me and my family standing in front of our house in the suburbs in England, in a place called Essex, which is quite close to London. And this, I think, is a very typical immigrant photo. They're all of us in our, very smart clothes, standing in front of our house and our car. And we had moved from Bombay in India in 1982. My parents had kind of lived in the UK and moved back and forth, but moved permanently in 82 with me and my older sister. So that's me in my very fancy check coat, which I actually wish I still had. And kind of, we were a very medical family. So my mum was a GP or a family doctor, and my dad was a dentist. And I want to talk to you a little bit about how some of my really kind of early experiences impacted me, including losing my voice to an extent. So when we moved to the UK, I didn't speak English. I spoke my mother tongue, which is Marathi, which is what we spoke at home. And I didn't really speak English on a daily basis until I went to school when I was aged 5. So obviously became fluent in English. And every summer we'd go back to India to spend time with family. So we'd go for about 2 or 3 weeks, and we'd have the most wonderful time seeing cousins and playing with cousins, and going back to speaking Marathi again. And it was when I was at primary school that my head teacher said to my mum when we came back from the summer holidays, every time she comes back from India, she comes back with an Indian accent, which, I think she needs to lose. She needs to lose that Indian accent. And my mum, I think, was very, really wanted us to fit in, being children of immigrants. It was very important to her and my dad that we fit in. So she was very strict then about us speaking English at home. And very sadly for me, I lost the ability to speak my mother tongue, Marathi, which to me feels like a significant loss to this day, although I can still understand it. And it also really made me aware of my voice. So when I was at school, I'd start thinking about how did I sound? What kind of accent did I have? And I kind of went from being someone who did speak in class to someone who was very shy and quiet. And all my school reports at the time said, she's very shy, she needs to speak up more. But I was afraid to. I was effectively quietened. And, that wasn't me at home. I was very loud, probably quite naughty, quite irritating to my older sister at home. So in professional spaces at school, and from then on, I became very quiet, and that has something that's very stayed with me. And even now, in my 40s, I still think twice before I put my hand up to ask a question at a conference or in a large public space. That kind of shyness, that silencing, has really stayed with me. But my parents being medical did impact also on the career that I chose to go in. And my mum, who's pictured here, as I said, was a general practitioner, a family doctor, but she really wanted to do gynecology. So she was really interested in women's health. But when she got to the UK, she was told, you'll never make it in the specialty because you're a woman and because you're a woman of colour. So don't even try. So she was discouraged from the start, and she went on to have, a great career in family medicine and managed to do women's health and sexual health on the side. And I think she's had a big role in influencing what specialty I ended up doing. So I've ended up in the specialty of genitourinary medicine, otherwise known as sexual health and HIV. So, as I said, my mum was a big influence on me, and I can remember going to school and walking down the corridor in school, and people in the older years would sometimes stop me and say, "Oh, I saw your mum yesterday." And what they were trying to tell me was, I'm having sex. And I went to the family planning clinic, and I saw your mum. So they're kind of telling me, look at me, I'm so mature, I'm having sex. So I remember that really stayed with me. But also my mum's real passion for reproductive rights stayed with me as well. And I think that's what made me choose this specialty. And I started training in it in 2008 in East London, which is an area that's incredibly diverse. It's an area of great inequality when it comes to kind of socioeconomic status. There's a lot of migrants. There's people from all walks of life. So I kind of fell into this specialty of sexual health, which luckily for me, I loved. I had the greatest colleagues, the greatest patients, and also it was really, really interesting medicine. So I felt very lucky to be in that space and, this being my career. And then during my career, working in East London for longer, I started to learn more about health inequalities. And that was really driven by the people I was seeing in clinical practice. So thinking about who finds it hard to access care, why are they having worse outcomes than others? So that really kind of pushed my interest. And it led on to the first research study that I ever did, which was published in 2012. And this was looking at the issue of intimate partner violence amongst women living with HIV. Um, so there is a real link between HIV amongst women globally and intimate partner violence. So your chances of getting HIV around the world goes up if you experience partner violence. This was something that was well known globally at the time, but no one had ever looked at the issue in the UK. So it wasn't really talked about much. It certainly wasn't in any guidance, something that we were made to be aware of. So myself and my colleagues thought, I think we need to see, is this happening in the UK as it's happening elsewhere? So what we did was we surveyed the women attending our HIV clinic to see whether they'd experienced intimate partner violence. And of course, we found that it was a huge issue in the UK as well, because why would it be different to the rest of the world? And what we actually found, sadly, was that over half of the women attending our clinic had experienced intimate partner violence in their lifetime, which was double women in the general population. So this was a significant issue, and it led on to being part of guidelines for people working in clinics to safely ask women and other people about their experiences of violence, so they could be signposted to organisations to help them with that. So this was kind of an important bit of research for me, which I learned a lot about working with others, working with patient groups, and doing research that had real impact and that impacted policy and national guidelines. And that was kind of been a theme for me throughout my career. So as well as the clinical work, the research I've been able to do has been mainly around health inequalities to do with gender and ethnicity within sexual health and HIV, and also outside of that. And that, again, I've been lucky to have that be part of policy. So, for example, some of the work I've done on racism and sexism in HIV in the UK has been cited in policy papers by Parliament, which has been, a really exciting thing to do. And an important part of that research and that work has really been around collaboration. And that's been kind of working with colleagues in policy organisations, in charities and patient organisations, and really thinking about educating our colleagues, educating the general public, educating patients about issues to do with sexual health and HIV, and thinking about how we can reduce health inequalities. That's been an important part of the work as well. And it really led on to doing some exciting things. And, I would say this kind of work that I've been lucky enough to do with my specialty has really helped me find my voice. So it led on to doing things which I never thought I'd do as a doctor. So, for example, appearing on TV talking about HIV stigma in South Asian communities in the UK. I was also part of a film called Faces, which was produced by a charity called NAS in London, which is a sexual health charity for people of colour, where we got funding to make a film, which was about HIV amongst Black African communities in the UK and thinking about how to raise awareness of it. And I was part of the writing group for that, which is a really interesting way to think about disseminating science. And rather surprisingly as well, so they filmed part of the film within my sexual health clinic and they needed someone to play the doctor. So I ended up being an extra in the film and I'm in the film playing a doctor with my name, but thankfully no lines because I actually cannot act at all. But, it's been luckily for me, I've had the chances to take my research and clinical work and use it in more creative ways. And I think it's been part of finding my voice. And, I was very honoured to be recognised with this International Women's Day recognition as a woman changing the world by one of the newspapers in the UK. So this, I think, sounds, like a story of intention and success. This is what I wanted to do for a long time. I lost my voice. I found it again by doing all this work. But actually, it wasn't as straightforward as all of that. And there was a lot going on in the background, which I wasn't talking about. So during this time, certainly that decade of finishing my training in sexual health and then becoming a senior doctor and doing all that research and that clinical work, um, privately, things weren't going so well. So me and my husband were trying to get pregnant and not succeeding. And during the investigations for that, I was diagnosed with endometriosis and adenomyosis, which are very common conditions that affect people who menstruate. And I can remember coming round from the operation where they diagnosed me with these conditions, and the surgeon saying to me, you're never going to get pregnant naturally. You need to have fertility treatment, which we did. And sadly, 4 cycles of IVF later, we hadn't managed to get pregnant. And this finished about 10 years ago. So there has been quite a period of time since that happened, but still learning to come to terms with that kind of grief of not being able to have a biological child. That has been quite a journey. And something that I was probably very discreet about at the time. It wasn't something I talked about much. So, on the surface, you may have seen this person who is very successful in their work, speaking up, advocating for others, but kind of privately having a lot of personal issues going on and a lot of grief. And this is something that I've been lucky enough to kind of be able to process in the last couple of years. I was invited to submit an essay to this anthology called No One Talks About This Stuff, which was published this year. And it's got 22 authors talking about their experiences of almost parenthood. So this is people who haven't been able to get pregnant, people who've had miscarriages, stillbirths, people who haven't been able to have children because of their social circumstances or their economic circumstances. And it has been described by reviewers as being a support group in a book. And I was able to share my story there. So I just wanted to highlight this just in case anyone is going through any of these issues. And this was also kind of my first time of being a patient. So I'd been very lucky to be, well until we started to try and get pregnant. And that's when I got my diagnoses and started having all these different treatments. And I think being on the other side of the curtain as a patient was very eye-opening for me. And in fact, it was some of my experience of being a patient which led on to me writing this book, Unheard: The Medical Practice of Silencing. So this is a book about who gets listened to and who doesn't in medicine and how it exacerbates health inequalities. And it was an experience for me as a patient. So during our 3rd cycle of IVF, I just had my eggs collected, and as usual, I felt very bloated and slightly in pain, which is a normal kind of side effect because the hormones are still really stimulating tissues and it takes a while to die down. But this was very different to my previous cycles, and I was in a lot more pain than I'd ever been. And that was despite taking kind of all the painkillers I had at home. And my husband was concerned, thank goodness, and he took me to the emergency room. And we were concerned that I may have a complication of IVF called ovarian torsion, which is a surgical emergency. It's very rare, but it can happen. So I was admitted, I was given really good pain relief, and the next day I had a scan which thankfully showed I didn't have ovarian torsion, I didn't need surgery. And the healthcare team thought that all the hormonal treatment I was taking for the IVF had overstimulated my endometriosis, and that was what was causing my pain. So I needed to stay in to have pain relief. But I think without that kind of more serious diagnosis of a surgical emergency, every time I asked for pain relief, I was denied it. So the healthcare team made me feel like I was exaggerating my symptoms to get stronger painkillers. And this was not what I expected at all. And it was only after a few days of my husband advocating for me to get the pain relief I needed that I was finally not in pain and able to go home. And of that experience, I remember thinking at the time that I didn't want to complain myself, and that's because I didn't want to be seen as a nuisance. I thought I would get worse care from the healthcare team. And also, when I went home, I didn't complain. I wanted to forget about it. And I felt, as time went on, I felt really ashamed and quite guilty that I hadn't complained. And I felt like I'd been silenced because of that shame. And I felt guilty because I knew that when I was in hospital, I was in a very privileged position. I was a doctor in hospital. I was a senior doctor at the time, and I could speak English. I didn't have something life-threatening. I had someone who could advocate for me. So if that happened to me in my privileged position, what on earth happens to everyone else? And by not talking up, by not speaking up about it, I felt like I was part of the problem. So that's the reason I've written this book. One of the reasons I've written this book. Um, the book basically goes against the argument that for better care, patients just need to speak up. As I've shown, it's very hard to speak up when you're at your most vulnerable, when you're unwell. And actually, we shouldn't be relying on individual patients to speak up. We in healthcare, we need to listen better. So this book is kind of my exploration of trying to understand why people aren't listened to in healthcare, and some people in particular. And during that time, I discovered that this practice of silencing and of not listening to people doesn't just occur in hospitals and in the consultation room. It actually goes wider. It happens in healthcare research and in the workforce. And this all impacts on health inequalities. The second reason I wrote the book was because I'm a doctor and I'm guilty of not always listening to the best of my ability at all times. And I wanted to really understand why that was. And I found that was partly to do with our training and the way our health systems are set up. And I also thought about the patients I see. So the patients who I work with, whose voices are never heard by those in positions of power in healthcare. So people who decide policy and funding. And there's this wonderful quote by Arundhati Roy, which I include in the book, which I think says it all really. There's no such thing as the voiceless. They're only the deliberately silenced or the preferably unheard. So I really wrote the book to think about those people who are trying to speak up. They're just not being listened to. And it's a long book, so I'm not going to be able to tell you too much about it. But in it, I do cover how patients are silenced. And we know this happens very commonly, sadly, when we look at patient safety reports. Missed, they feel disbelieved, they feel gaslit and unheard when they go to see their doctor or other healthcare professionals. And this leads to real harm. So we know that it can cause delayed investigations, diagnosis and treatment. It means that people stop speaking up. So if you're going to your doctor and your symptoms aren't being taken seriously, what's the point in carrying on? So you may not speak up about your symptoms. And it can really impact the doctor-patient relationship. So it can increase mistrust in your physician, and it means you may avoid healthcare because again, you're not getting the care that you need. And we know that this is most likely to happen to patients from marginalized groups, so particularly women and other gender diverse people. It can happen to people of color, people due to their ability, their age, to their class, to their sexual orientation, or to their religion. So, for example, my experience of being a woman of color may have made me less likely to be believed in that position in healthcare. And it also happens to patients because they're unwell. So having a long-term condition in itself may mean that people are less likely to believe you because they may not think that you're competent or to speak up about your condition, or perhaps you're confused, or maybe you don't have enough distance from yourself to be objective about your condition. And we also know that patients in marginalised conditions are less likely to be listened to in healthcare. So these include people, for example, who have conditions where we have little knowledge of how to diagnose or treat them. So conditions like fibromyalgia, long COVID, ME, CFS. So having a marginalised condition can mean you're more likely to be silenced as well. And really, what this all boils down to is about credibility. When we speak up, how credible are we? So, who is deemed a credible speaker or producer of knowledge, who is less likely to be believed because of their social identity. So again, I guess to give an example in healthcare, I'm going to give you two. So endometriosis and sickle cell disease. We know that in these conditions that people, when they speak up, they don't get listened to by their healthcare team. So endometriosis, it's often women who are less likely to be believed because they're not deemed as being credible when they speak up. So they suffer what's termed a credibility deficit. So their diagnosis of endometriosis becomes delayed. And in fact, in the UK, the time to diagnosis is 8 years, which is ridiculously long. And then we know that it was sickle cell disease. People due to racism are less likely to be believed when they complain of symptoms. And sadly, there's far too many instances of people suffering real harm because their sickle cell crises have been missed. And in fact, even in just this week in London, it was reported that a young man died in the emergency department. He said, "I'm having a sickle cell crisis," but the healthcare team didn't believe him, and shockingly, he died. And again, we can say that's probably due to the effects of racism, that he wasn't listened to, he wasn't deemed to be a credible producer of knowledge or speaker. And this kind of concept of who's deemed to be a credible producer of knowledge and who gets listened to and who doesn't get listened to happens in research as well, and particularly in global health. So we know, for example, that researchers in the global north are seen to be more credible when they produce knowledge. So they're more likely to get jobs, more likely to be funded, and more likely to be published. And it means that researchers in the global south are less likely to be able to produce knowledge that is important for their communities. So we end up with these knowledge gaps where, because the researchers aren't seen to be as credible, it means they can't do the research on the conditions that are important for their communities. And we also see this with minoritized researchers as well in the global north. So, for example, in the UK, we have very few Black female professors, and that's because of barriers such as sexism and racism, which means that minoritized researchers don't get to those top levels of research, which means that they can, do the research and produce the knowledge that is important for their communities. So silencing can happen in research in global health as well. And in the book, I also look at how this silencing happens in the healthcare workforce. So really thinking about, again, who gets listened to and who doesn't, and how that impacts on leadership. And in the UK, in the NHS, a report was released called the Snowy White Peaks, which said that basically in the NHS, we have a very diverse workforce, but not in leadership. In leadership, it's mostly white men. And again, that impacts on which patient groups are focused on and which diseases are looked at and which gets the funding. So this silencing in the medical workforce can have a real impact on patients as well and their health. Um, and in the book is meant to be a positive book. So I kind of explore these issues and look at ways that we can address them at different levels and systematic ways. But of course, during all this time of silencing, patients are never just sat back and, let themselves be silenced. And I talk about patient activism, which I think is an incredible force for good. And a good example of this is from my own specialty around HIV activism, where, people with AIDS in the early 80s and their allies basically changed HIV from being a condition that was terminal to one that was treatable within 20 years. So for them, silence literally equaled death. And this is the logo of ACT UP, which was a big HIV activist group, which is still running. And these activists changed science, actually. They changed how clinical trials are run. They changed our kind of image of who is deemed to be a medical expert with lived experience seen to be increasingly important, and they changed how healthcare is done. So, these patient activists are just one example of a patient activist group, but they've had a massive impact. So patients have always fought to be heard. And the main argument of this book is really about how we can amplify patient voice and how we can better value lived experience and really recognize that it is on par with other other expertise, so medical expertise and research expertise. Patients are experts in their own bodies. They know what's going on with them more than anyone else, but also they may know more about their condition, so they may have learned expertise as well. So we need to better value lived and learned expertise, and we need to include patients in all aspects, I think, of healthcare and research. So in medical education, in service development, in research, so through co-production, for example, and in health promotion. But it's really important that we do this ethically because we need to avoid reinforcing harm. So, for example, if we're asking someone to speak about their lived experience, that can be traumatizing if you're having to recount really difficult things again and again. So it's important we think about that and we provide support. So that could be pastoral support, that could be training. And it's important that we recognize that they are providing epistemic work, so knowledge work, and that we remunerate them, we pay them. We need to make sure we don't tokenize, we include diverse voices, and we need to make sure that when suggestions are made, so for example, if you have some patients in your research group who are doing the research with you, or they're helping you develop your service, that you act on their recommendations so they know they've been heard and taken seriously. So this was a very quick whistle-stop tour, I think, through hopefully the theme you saw there, which is around losing a voice, finding it again, and amplifying marginalized voices. So I kind of want to leave you with a challenge of, are you ready to listen? And for that for you may mean a different thing. So it may be about listening to the voices of the most marginalized. So perhaps, taking a friend with you to accompanying a friend to their hospital appointment, for example, if they're nervous about seeing their doctor. It may be saying to someone else, I've been offered this opportunity. Would you like to do it? So perhaps, making space for other people to speak. So I think there's different ways that we can do it. So have a think yourself, how can you listen better? And how can you advocate for the more marginalized voices in your context better? And I always like to finish a talk with reading recommendations. And these are 4 books which have had a massive impact on me. So I'll let you have a look at that. Um, and yes, I'm going to end there. We have time for questions. So I just want to say to you, thank you so much for listening. And this is how you can contact me on my different social media handles. So I'm going to stop sharing the screen and I look forward to some questions.
Amazing. Thank you so, so much. That was super incredible. And again, I've read your book and it's just incredible. I've actually read almost all the books that you shared as well, and I highly recommend them as well. They're truly inspirational. I think we actually had a question in the chat from Emma who said, "Thank you so much for your vulnerability and sharing your personal story. In your opinion, on a day-to-day level, how can we support people in our lives who feel discouraged that healthcare providers aren't listening to them and feel disillusioned?"
Yeah, I think that's lots of people have had bad experiences, and I think being that friend, that ally can be really helpful. So, in the book, I do give a list of kind of things that people can do, but I think one thing can be accompanying your friend. So, going with your friend to their appointment, maybe them kind of prepping you beforehand, saying, this is what I want to get out of the appointment. So, if they're not able to ask those questions or they feel they can't speak up, then you can advocate for them. And so that's one thing that people can do, a practical thing to kind of help their friends. And I always say you should know your rights in healthcare. So you do have a right to a second opinion. And perhaps, again, if you're with a friend and they're not able to ask that, you can ask that. And you also have a right to complain as well. And that's very important to know.
No, amazing. Thank you so much. And I feel like this is like a very common struggle that a lot of people feel is like also understanding that your own boundaries and how you work within those spaces. I think it's super complicated in this field, but super important to discuss. Okay, I had another question. I think it was just directly sent to me, but I'll read it out on behalf of the person. But it was, how do you protect your own well-being when creating or engaging with content that really delves into like trauma or injustice? So do you have any advice for other people who are writing about these things or who are kind of activists in this field of balancing this idea of like self-care and passion and advocacy and all these different roles that we kind of play as humans in the healthcare space?
Yeah, I think that's such an important question. And actually, I do talk a bit about some of my experiences just during COVID where I felt very overwhelmed and very close to burnout. So I think it is recognizing that, isn't it? It is recognizing when you feel overwhelmed. And part of the listening is actually listening to yourself as well and really recognizing when you feel tired, when you need to have a break. So that's one thing I would say. I would say also, if you're sharing things that are vulnerable, really think about what you want to share. So what I have shared today and what is in my book is what I feel comfortable sharing. I feel like I have had enough time and distance from it to feel able to talk about it without it affecting me too much. Um, so yeah, don't feel like you have to be vulnerable and share everything. Really think about what you want to share. And finally, find other things to do that apart from your work. It's really important to have that balance, and I've been rubbish at it. And actually, that was one thing I wanted to say was, I think the reason I really went into my work was because I was having difficulties trying to get pregnant. So work was a diversion, but I probably went a bit too far that way. So find fun things to do. Do things with your friends, do stuff that is not in any way related to the more serious work that you are doing. It's so, so important. And know when you feel tired and recognize that, take a break.
No, thank you so much. I feel like that's incredible advice. And I feel like that's like something that, often people talk about in research law and other spaces is like, how do you actually remove yourself when your work kind of becomes your life because you're so passionate and excited about it? And how do you kind of balance those things? Um, yeah, thank you. So we have another question, which was in your role as a doctor, how do you build trust with patients so they feel safe to share and listen to?
So I wrote a lot of the book when I was took a year out to do a master's. So I worked during COVID and I was very exhausted and I was lucky to be able to take a year out and do a master's. And I wrote a lot of the book during that time. And I coming back just thinking, I'm going to be the best listener when I'm doing my clinics. And after about 3 months, I thought, oh, this is really tiring, actually. Listening is really, really hard, but it's something that I am still practicing every day. And what I try to do, I'm much more reflective than I used to be. So I now very consciously try not to interrupt. So one thing doctors do is interrupt very a lot because we are taught to take a very focused history. So we want to hear about some things, but not other things. So things we think are important. So we interrupt a lot. So I consciously will try not to talk for the at least the first minute or so and just see what the patient has come in with. And I also, try to when I ask questions, I let the patient answer and I try to show them that I've heard them. So again, what's difficult for doctors is we're really used to wanting to fix people, and when we can't fix people, that makes us really uncomfortable and we may shut people down. So again, trying to learn just to listen when someone's telling me about something difficult, even if I can't help them, trying not to give advice when I can't give advice sometimes, and recognizing that just listening, making someone feel heard is in itself therapeutic, just as much sometimes as me writing a prescription. Validating people's experience, I think, is really important.
No, thank you so much for sharing. I think we have time for probably about two more questions. So I see a question from Hannah in the chat, and then I know that Mabel, you've raised your hand. So I'm going to start with Hannah's question, then we'll end it off with Mabel. So Hannah wrote, thank you so much for a great talk. Please could you elaborate a bit more on how you think medical education has impacted your own experience with silencing patients and what you wish could be changed about medical education?
Yes, so when I started writing the book, I thought it was going to be a book about bias because, as we know, it is the most marginalized patients who are least heard in medicine. But actually, during my research, I found actually we inherently doubt and are skeptical of patients. It's come from since the medical profession existed, actually, this inherent doubting of patients and disbelieving patients and thinking patients are lying to us. It's been recorded for, hundreds and hundreds of years in old documents from physicians. So we come from this inherent thing of thinking, I don't trust what my patient is telling me. Um, and actually, that really needs to change. And that then comes across within our medical education, where we have a very biomedical focus, where we're only interested in the things about a patient's life that are relevant to a diagnosis and treatment. We don't have a very, holistic approach. And I think we're not taught about the value of listening. So again, that makes us silence patients. When we can't fix people, we become uncomfortable and silence patients. So there's a lot, I think, in medical education that needs to change. And I think it is changing. I have to say there's a lot more emphasis on patient involvement in the medical curriculum now, which is a good start. but I think we need more.
No, no, thank you so much for sharing. I think this is a pretty ongoing thread of conversations that we have a lot at Medical Her Story, which is kind of this ideas of like, how do we incorporate so many different diverse voices that are not just also physicians or patients, but also other people, like, whether it be like family members who are also seeking help about other family members. So it's really great to hear that that's kind of being incorporated a little bit more into a lot of that curriculum. So thank you so much for sharing. I think we have time for one more question. So Mabel, I see that you've raised your hand. If you feel free to ask your question.
Hi there. Thank you. So sorry, is everything okay? I'm having a bit of lagging issues. Is that okay? Thanks so much for the talk, and I've read your book and I've loved it. My background is actually in anthropology, so I'm currently looking at medical anthropology in this realm. So talking about voices and listening. And in your opinion, you talk a lot about how so many different types of voices, especially marginalized voices, are not listened to, and for the reasons and for so many reasons. Do you think there's space in research to delve more specifically into language in that area? Is that something you see lacking in research, or maybe you could highlight other areas where you feel like deserve more attention in the academic sense? I know that's a huge question.
So, so I actually haven't seen much research on language, and I would love to see more. And that whole thing I was saying about learning that this inherent skepticism of patients is in our training. It's actually in the language of medicine. So, we are taught medical language, what to write in medical notes, or when we're presenting a history to our colleagues, and we say stuff like patient complained, patient denied. This is very language which disempowers patients. And again, saying, if they claimed or denied something, it sounds like it's a legal document. We're talking about patients here. So I would love to see more work on language. There's a little bit about how it disempowers patients. And, I mentioned HIV activism changing some of that language of medicine. But I would love to see more on that. So, yeah.
Amazing. Thank you so, so much. Thank you to everyone for your incredible questions. Thank you so much for coming to